Okay, we're going to wrap up our discussion on blood by covering the last two major topics. First one is platelets and blood clotting, and then the last topic is blood typing. So let's talk a little bit about platelets in general, and then we're going to dive deeper into the whole process of what we call hemostasis, which is stopping blood loss. So per microliter, about 150,000 to 400,000 platelets per microliter. So that number is, significantly lower than red blood cells, but significantly more than white blood cells. They're going to be the smallest formed elements, and that's because they're actually not actual cells. They're cell fragments, and we'll talk a little bit more about that coming up. But what happens is there's a cell in your bone marrow that breaks off little pieces, and those little pieces then become circulating platelets in the bloodstream. And they're going to circulate for about 5 to 9 days. So a lot like a red blood cell, your bone marrow has to keep producing them as you remove them. All right, so they need to be removed from circulation as well. Since they're just cell fragments, they have no nucleus. They do have some vesicles that contain some of the chemicals that they're going to release. All right, so platelets aren't just these fragments that don't do anything. They actually release chemicals, and those chemicals are going to promote a lot of the key processes that occur during blood clotting. So what they do is they form what we call a platelet plug. The platelet plug is kind of a temporary patch to a broken blood vessel, and that just buys us a little time. So we can then bring in more players that are involved in the process of forming a nice solid blood clot. This whole process is called hemostasis. So hemostasis is the process by which we stop blood, all right, stopping blood loss. And platelets are a player in that, but they don't do everything. There's a lot of other proteins and molecules involved. All right, so they're going to release chemicals that promote what we call vascular spasm, which we'll talk about in a minute, and blood clotting. Now, this should make a lot of sense. If someone has thrombocytosis, that's a high platelet count, so much higher than this 400,000 per microliter. And if you have a lot of platelets, you're at risk of forming abnormal blood clots. So the body has a method of forming blood clots, preventing inappropriate blood clots, and then dissolving blood clots. And there's a delicate balance with all those. So high platelets kind of tip the balance towards the formation of abnormal blood clots. Thrombocytopenia is low platelets, and just the opposite could occur. So now a patient might be at risk of bleeding excessively. Okay, so let's look at the overall process. So what we're talking about on this slide is hemostasis, all right, stopping blood loss. There's 3 key steps. You'll notice platelets are involved in the second step, but there's a step before that, and there's a step after the platelet plug. So step 1 is called a vascular spasm. So you'll notice that here's a damaged blood vessel, okay, a little break there, and immediately, almost like a reflex, the muscle in that blood vessel will contract and cause vasoconstriction. So vasoconstriction is when the diameter of a blood vessel decreases because of that muscle contraction. Now what that'll do is just prevent excessive amounts of blood coming out of that injury. All right, so it reduces blood loss, but it's not going to fix the problem, which is the damaged blood vessel. All right, step 2 is where the platelets come in. And I want to point out a key player in the formation of the platelet plug is collagen. Collagen is a protein. You've heard about it before. It's found in most of our connective tissues. So underneath this inner layer of a blood vessel. So the inner layer of a blood vessel is called the endothelium. It's nice and smooth. So blood cells and platelets can slide along the inner surface, no problem whatsoever. Underneath that layer is connective tissue, and there's collagen in there. So when a blood vessel gets damaged, the collagen gets exposed into the blood vessel, all right? And collagen and platelets really stick together. So so the collagen provides almost like a landing for platelets. So you can see, you might get 1 or 2 platelets sticking to that collagen. All right, that's a really early step in the formation of a platelet plug. So that's called adhesion to collagen. Once it adheres to the collagen, it kind of knows what's going on. It knows that if I'm sticking to this collagen, there's a damaged vessel. So I need to start releasing chemicals that will bring in more platelets. So it's going to attract more platelets, and it's going to allow the platelets to start to kind of clump together or aggregate. So we have 3 key steps here in the platelet plug: adhesion, release of chemicals, and then aggregation, which is the collecting of these new platelets that arrive at the scene. All right. Some of the chemicals that are released by these platelets include ADP, serotonin, thromboxane A2. I'd like you to recognize those as being chemicals released by platelets. That makes a really good question. What formed element produces or releases these chemicals? What they do collectively is they're going to help attract more platelets. They're going to make sure that blood vessel stays constricted. That's a job of serotonin. It keeps that blood vessel nice and constricted until we can fix it. And then thromboxane kind of plays a role in both of those. It does some of the aggregation and the constriction. And we're going to see in a little bit that we have medications that block this molecule. So for example, aspirin. Aspirin is often given when someone might form abnormal blood clots. Well, what aspirin does is it blocks this molecule so you don't get this improper platelet aggregation. So we have the platelet plug. Notice now we've kind of filled that injury there with platelets. But that's kind of, like I said before, that's a temporary fix there. It's not going to be strong enough to keep that blood from leaking out indefinitely. So what happens at the 3rd step is what we call the actual clotting or coagulation step. And what happens here is we start to form this, what's called a fibrin mesh. This fibrin comes from that protein we learned about that's in the plasma called fibrinogen. We're going to see that fibrinogen is kind of inactive unless you need it. It has to get activated, and then it forms this meshwork. And that mesh really helps to trap larger things like red blood cells will stick in there, more platelets will stick in there, and now we've got a nice solid blood clot. It allows us to repair this blood vessel, so you got to get some repair going on in there. And then that blood clot, very importantly, has to dissolve. We have to have another kind of set of reactions that dissolve that clot, because if we don't dissolve a blood clot, it could get kind of released and circulate throughout the body and cause blockages in blood flow. So just as important as forming a blood clot, we need to be able to remove that blood clot. The clotting step is kind of complicated, and we're going to keep it as simple as possible, but there's actually 2 pathways that kind of lead to this formation of that final blood clot. So let's take a little, this is another drawing, kind of a little more detail than we need to go, but you'll notice first that we have to form the platelets. They're formed in bone marrow when the megakaryocytes, which are cells, they're big cells, right? Mega means big. They're big cells that splinter. So they'll kind of just break off these pieces. And one of these megakaryocytes can actually form thousands of platelets. The platelets have a short lifespan, 5 to 9 days. After that, they're going to get removed. Just like red blood cells, the spleen is a major player in removing those old platelets. So what we see here is just kind of another drawing. Here's the damage, the injury. Notice here are the endothelial cells. This is a nice, thin, smooth inner surface, right? It's a simple squamous, if you remember that from A&P1. So nice and smooth. All of a sudden we get this injury, and notice what's underneath here is collagen. These are all like the collagen fibers. And the collagen, when it's exposed, those platelets are going to really stick. All right, so we get that platelet adhesion. Then we get this release of these chemicals, which are going to bring in more platelets. So we get more platelets. They start to aggregate. They just kind of grab onto each other and start to fill up this injury and form that platelet plug. Notice here's where I mentioned a couple of our antiplatelet medications. Aspirin, we often refer to as low-dose aspirin. When you give 81 milligrams a day, that can act as an antiplatelet medication. So it reduces the risk of forming abnormal blood clots. Plavix is another similar antiplatelet medication. Now, what patients need to be concerned about, though, when they have these antiplatelets is the propensity to bleed. So they're going to bruise really easy. If they do get any kind of scrape or cut, they have to be extra cautious about getting that blood clotting. Okay, so that last step, let's take a look at it. This is one of these complicated figures that every A&P book has. It's just slightly different. Notice the end game here. A lot of times when you look at a figure like this, try to see where the end is first. So what are we trying to do? What we're trying to do is form that fibrin clot, right? We got to get that fibrin to form those threads and form a nice blood clot. Just so happens there's two ways to get there. There's what's called the extrinsic path and then the intrinsic path, and they share what's called a common pathway. So they both get you to here, and then they share this last pathway. So we're not going to go crazy, but I want you to know a little bit about the difference here. The extrinsic pathway is activated when the tissue outside of the blood vessel gets damaged. All right, so it's tissue trauma. What happens is there's a molecule called tissue factor that kind of triggers this pathway. All right, so there's a molecule called tissue factor. Calcium is very important. We're going to see that calcium is important in multiple steps. So if you're asked, or I should say when you're asked, what really important mineral or ion is involved in blood clotting, it's calcium. All right, so notice it's involved here during the extrinsic path. It's involved over here during the intrinsic path. It's involved in a couple places in the common pathway. So calcium's vital. You got to have enough calcium to play the role in all these different pathways. And then you got some clotting factors, factor 5, factor 7, factor 10. And again, we're going to try to not make it overly complicated by learning all these different factors. Intrinsic pathway is when the trauma occurs kind of on the inside of the blood vessel. So extrinsic means outside, intrinsic means inside. So this is when those platelets stick to that collagen. That collagen is sticking or exposed to the inside of the blood vessel. Important clotting factors, so there's another factor called Hagman factor. Calcium is very important. Factor 10, and some others. So again, even I get confused with all these clotting factor Roman numerals. The common pathway kind of starts with this molecule called prothrombinase. Now, a little word of advice. Whenever you see ACE, it's some sort of enzyme. And most enzymes are going to turn one molecule into another molecule. So prothrombinase is the enzyme that converts prothrombin, and usually if you have pro at the front, it means it's kind of inactive. It's kind of waiting to be turned into something else. So it gets converted into an enzyme called thrombin. Thrombin is the one, right? That's the enzyme that takes that circulating fibrinogen that we have circulating around all the time in our blood and converts it. All right, it converts it to that fibrin, and now we got that nice mesh that's going to trap red blood cells and white blood cells and form that nice solid blood clot. All right, so most important things are to understand that there's a couple different pathways, right, that lead to the common pathway. They all require calcium. They all require a whole bunch of other clotting factors that we give Roman numerals to. But ultimately, the goal is to get this enzyme called thrombin so it can convert fibrinogen to fibrin. Okay? So, again, I don't want to drive us all nuts by having us memorize a bunch of clotting factors. But I also want you to be aware that if there's any defect in one of these clotting factors, the whole pathway is going to be affected. So there are a number of genetic diseases where a clotting factor doesn't work, and those diseases are called hemophilia. And there's a couple different forms of hemophilia based on which clotting factor is defective. A couple other points to make. The liver. The liver keeps appearing, right? We haven't even gotten to technically the liver is part of the digestive system, but the liver does a lot of different things. And one other thing it does is it produces a lot of our clotting factors. So remember, up till now, I think we've talked about the fact that the liver gets rid of bilirubin. So if it's not functioning, you might develop jaundice. The liver also produces clotting factors. So if you have, liver problems, hepatitis, liver failure, you're also going to have an impact on your ability to form blood clots. All right? So many of our clotting factors are produced by the liver. Some of our clotting factors require a very important vitamin for their synthesis, vitamin K. All right? So now, if you're ever asked about an important vitamin, your answer is going to be vitamin K. All right, vitamin K, we get it, naturally in a lot of our foods. We often refer to, leafy green vegetables as, a really important source of vitamin K. So if you're not getting vitamin K, you might have an issue forming nice, adequate blood clots. All right, let's talk about removing that blood clot. Again, just as important is to be able to dissolve inappropriate clots. So sometimes there might be a spontaneous clot form, and you want to be able to just get rid of that thing. You don't want it circulating in your blood. Blood clots that are in the bloodstream are like ticking time bombs because they can get stuck. All right, if they get stuck in a artery in your brain, they cause a stroke. All right, that's what a stroke is. They could get stuck in one of your coronary arteries of your heart, and they can cause a heart attack. They can get stuck in the lungs and cause a pulmonary embolism. So blood clots are great as long as they're appropriate. Sometimes we might form blood clots in our legs due to poor circulation, a lot of elderly individuals. So we've got a mechanism in place to dissolve those blood clots. Most of the time this works, sometimes it doesn't. And then when you do form a blood clot, you got to turn this system on so you can dissolve that blood clot. So fibrinolytic or fibrinolysis means you're breaking down the fibrin. You're dissolving it and getting rid of it. All right? So major player involved here is an enzyme called plasmin. All right, plasmin is what actively dissolves the clot. And a lot like fibrin, there's an inactive form. All right, so plasminogen And I'll give you a little word of advice. A lot of times when you see an inogen, it's inactive and it needs to be converted. So this molecule, plasminogen, gets converted to plasmin, then it dissolves the blood clot. And there's an enzyme that does this conversion. It's called tissue plasminogen activator. So it activates plasminogen and turns it into plasmin. Okay? Now what's very interesting with all this stuff, I believe, is learning these medications. There are anticoagulant medications and there are thrombolytic medications. So anticoagulants are going to delay, suppress, or prevent blood clotting. So sometimes someone is prone to blood clots. A lot of times if someone has a surgery, you're going to activate a lot of blood clotting, and some of that might be abnormal blood clotting. So a lot of times after a surgery, people can be put on anticoagulants just to suppress any improper blood clotting. You don't want blood to clot if you're going to use it for diagnostics. So if you've ever had your blood drawn, that little test tube, if you ever look at it before they draw the blood, there's something in there, right? It's not a completely empty test tube. What it has are some anticoagulants, so when the blood enters that test tube, it doesn't clot and solidify. Blood that leaves the blood vessel is prone to clotting. So if you've ever, bled and a little drop of blood lands on the floor, that blood almost spontaneously blood clots or clots. So if you're going to put blood in a test tube and use it, you got to prevent it from clotting. And the molecule that does that quite often is called EDTA. What it does is it gets rid of all the calcium. It kind of sequesters the calcium so it's not there in order to do the blood clotting. So heparin is a molecule that blocks the thrombin. Remember, thrombin converts fibrinogen into fibrin, so you can block that. EDTA removes the calcium necessary for blood clotting. Coumadin, or warfarin, reduces or blocks the vitamin K. So remember, what's important for blood clotting? You got to have thrombin, you got to have calcium, you got to have vitamin K. So we can design drugs or find drugs. A lot of medications were just found in nature and then we've kind of modified them. But these agents or drugs or molecules all block some vital step or some vital molecule in blood clotting. But what if you already have a blood clot? What we might use there is a thrombolytic agent. These are often called clot busters. So these are given if we already know there's a blood clot. And there's an enzyme that they discovered in bacteria called streptokinase. We don't use that as much anymore because now with genetic engineering, we can make human enzymes. And they actually made tissue plasminogen activator, or TPA, through genetic engineering, and now we can give that. And that's much more like the natural enzyme that converts plasminogen into plasmin. So given this as a drug, it activates this enzyme and then dissolves the blood clot. And this will be given, TPA will be given if there's a patient coming in who we believe is experiencing a stroke or experiencing a heart attack due to a blood clot, or might have blood clots in their legs or in their lungs. That's kind of always in an emergency medicine toolbox, TPA. All right, last topic is blood typing. We might as well continue with this video. By this point, usually in a PowerPoint and set of presentations, you're a bit exhausted, right? You've gone through a lot here. Blood typing isn't easy. That's the problem. Sometimes we think it's easy, right? We've heard A, B, ABO. It's not so bad. I'm going to get you to the point where it all makes sense and you don't have to memorize. It's when you memorize you make mistakes. There's also going to be a separate video coming out. I already made that video. It's kind of a separate video going over blood typing a little better, using some other images and things. But that'll be either sent out by message or announcement or posted in the module. But we're going to give it a try here, and then when you watch that other video, hopefully together you will better understand blood typing. So I think we've heard of this, right? People have different types of blood, and some are compatible with one another, and some are not. So it's very important to be able to determine someone's blood type if they are in need of a blood transfusion. Blood typing is based on red blood cells. All right, so we're kind of going back to the red blood cells. And red blood cells have different proteins on them. And some of these proteins vary. So some of them we give letter designations like A, B, are two of these proteins. And we're going to call them antigens. An antigen is something that could be foreign. Okay, so a lot of times we use the word antigen if we're dealing with viruses and bacteria and microbes, because those microbes are foreign. So we might call them antigens. Now, the reason why we call these proteins antigens is because if someone doesn't already have them on their red blood cells, and you go and put them in someone, they can act as a foreign antigen. Okay, so an antigen is just some molecule that when put in a certain human, it could be foreign. And when the immune system identifies an antigen, it's going to attack it. Okay, so if we're putting someone's blood into another person, we don't want that person to attack that transfused blood. All right, but technically they are membrane glycoproteins. So they're on the membrane of the red blood cell, and they're proteins that have a little some sugar groups attached. That's the glyco part. They're also known as agglutinogens. I don't really use that term. But what happens, so now we got to learn what an antibody is. So an antibody is when you attack the antigen. All right, so let's get back to the microbe analogy. So if I get a virus, the virus is the antigen. It's the foreign material, if you will, that got into my body. Well, my body's going to identify that as foreign, and it's going to produce antibodies that are going to attack those antigens. Okay, so before we move on to blood type, we got to have a thorough understanding of the difference between an antigen and an antibody. Okay, what happens in transfusion reactions is you put blood that has an antigen on it into a patient. They produce antibodies, and they attack those red blood cells. And it causes lysis of the blood cells. So hemolysis or hemolysis is lysing of the blood cells. All right, what happens next is they release all that hemoglobin into the plasma. And that's a lot of protein to have in plasma. And the kidneys have to deal with that. Okay, so you totally overwhelm the kidneys, and that can lead to kidney failure. So we want to avoid these transfusion reactions. These blood groups are based on these antigens, okay, and the different combination of these antigens. And there's all kinds of different ways to type blood. There's some that I've never even heard of, but the most common blood typing mechanism is the ABO blood typing mechanism. And then what we're going to add is the RH grouping. So we're going to combine what's called the ABO system with the RH system in order to identify 8 different blood types. All right, so we've got the ABO group, and that's based on 2 antigens. You've got A or B, or neither, or both. So that with 2 antigens, you've got 4 possibilities. If you have A, you're A. If you have B, you're B. If you have them both, you're AB. If you have neither of them, you are O. Okay? So that's 4 different options. The RH group, there's 2 options. You either have the RH antigen, so this is kind of like the A and the B. It's a protein on certain people's red blood cells. So you either have it, and therefore you're positive for it, or you don't have it and you are negative. So now with the combination of these two groupings, we can have 8 possible blood types. A positive means you have the A and the RH. A negative means you only have the A, and so on and so forth. All right? This is just kind of different populations and the kind of the distribution. You'll notice that the most common blood type in most, ethnicities is right down here. It's type O positive. The second most common is A positive. And if you put those together, that's the large majority of most populations. All right, so if you look at Latino, we can add 53 to 29 and you get, 82. When you look at Caucasians, you add 37 and 33, that's 70. If you add, Asian Americans, you got 39 and 27. If you have African Americans, you got 47 and 24. So A positive and O positive are by far the most common blood types. Okay, so what are we looking at? So we're going to start with just the ABO system and then add in the plus or minus. Remember, if you're plus or positive, you just have another antigen called RH. If you're minus or negative, you don't have it. All right, so we can double these 4 blood types. So what we're looking at in this first row are the antigens. Okay, so if you are blood type A, that name is based on this, what antigens you have. So you have the A antigen. They drew it just as this little lollipop. All right, so that's just this one of these proteins on the red blood cell. If you're B, if you're blood type B, you have a different one. All right, so they drew this little cone. So that's the B antigen. If you're AB, you have them both. You got A's and B's. If you're O, there's no O antigen. O means neither. All right, you don't have A nor B. Okay, now if we were to double this, you could be O negative. This would be an O negative, right? It doesn't have anything. If it was O positive, you would see an RH antigen on it. If we were to look at this one, if you're AB negative, that's what you're going to look like. If you're AB positive, you would have another RH antigen on there. If you're B negative, you would look like this. If you're B positive, you would have an RH antigen on there. And then same with A. If you're A negative, you look like this. If you're A positive, you'd have an RH antigen on there. Okay? So rule number 1 is the name of the blood type is based on what antigens you have on your red blood cells. Okay? Second thing we want to know is what kind of antibodies you would produce. Okay? Now remember, antibodies are what you might have to attack foreign blood. So the antibodies are never going to be against what you have, right? You're not going to have an anti-A antibody because then you would attack your own red blood cells. All right, that'd be crazy. You're not going to have an anti-B antibody if you have B blood. Okay? You're not going to make anti-A and anti-B antibodies if you have those antigens. If you don't have them, you're going to make antibodies. All right? So those are the antibodies. So I'll repeat. Step 2 is to figure out the antibodies. And they're going to be to whatever antigens you don't have on your red blood cells. All right? Okay. So now what we're going to do is compatibility. All right? So we're going to first do just these 4. Okay? So when you do a compatibility study, you're looking at a patient that needs blood. They're the recipient. And then you're going to look at donor blood. All right? That's the blood that's going to be given to the patient. We want to look at what antibodies the recipient could make. Okay? So if your recipient is blood type B, we want to know what antibodies. So they're going to make anti-A. So the last thing we need to do is put A in that patient, okay? Because they will use their antibodies and attack that blood. So if you're blood type B, you do not get A and you do not get AB, because both of those bloods are going to be putting in the A antigen that you have antibodies that will attack. Okay? If you are O, okay, let's say the recipient is O blood. Well, you better not put any blood that has A, and you better not put any blood that has B. So you can't put this in them, you can't put this one in them, you can't put that one in them. You can only put O blood in them. Okay? If you are a recipient and you are AB, well, look at AB doesn't produce either of the antibodies. So you could put all these in someone with AB. Okay? Now, the problem with all this is we have to also consider the RH blood group. Okay? Because you're not just A. You're either A positive or you're A negative. All right, so now let's look at someone who is A negative. Okay, so imagine this is A negative. Okay, if you're looking at the antibodies, they're going to produce this anti-B. They're also going to produce anti-RH. Okay, because they don't have RH, they're A negative. So if you're going to make the anti-RH antibody, you cannot give them any blood that is positive. Okay, so now you have someone who's A negative that needs blood. Well, what can you give them? Well, you can give them A negative. You know, that's the obvious choice. Give the patient the same blood that they are. You can't give them B, either positive or negative. All right, because of that B. You can't give them AB because of that B. All right, so you can't give them a B negative or B positive. You can't give them AB negative nor AB positive. Can you give them O? Well, you can give them O negative, all right, because O negative doesn't have the RH. But you really shouldn't give them O positive, because if this was O positive and you put it in this patient, they're going to have those anti-RH antibodies that could potentially attack those red blood cells. Now, there's a little hitch to it. You can actually do it once, because the anti-RH antibody is only produced upon exposure, upon an initial exposure. So you could do it once, but if you try to do it again, that's when the patient will have these anti-RH antibodies, and they will attack that blood. All right, pretty confusing when we add in that RH. Let's do another example. Let's say the patient is B positive. Okay, so now we have to kind of imagine that it's not just this B, there's also an RH in here. All right, now what antibodies will they produce? They'll only produce this anti-A. They're not going to produce anti-B, and they're not going to produce anti-RH. So if you're B positive, you can receive positive or negative blood. All right, as long as it doesn't have an A, okay, because you're going to be making this anti-A antibody. So can you receive A positive or negative? Heck no, because it's got an A, because you're going to attack it with this. Can you give them AB positive or negative? No, because it's got that A. Can you give them O positive or O negative? Yes, you can give them both. So someone who is B positive can receive B positive, B negative, O positive, or O negative. Okay? So it's all about comparing the recipient's antibodies, so what antibodies do they have, to the donor's antigen. Okay? So that's how you answer any compatibility issues. All right. The RH group has another little angle in pregnancy. Okay, so the most important thing about this RH, this positive or negative, is when it comes to an RH negative mother. Okay, so she could be A negative, B negative, AB negative, or O negative. All right, so if she's any of the four negatives, okay, we have to be concerned. All right, and the concern has to do with if she decides to have a second baby, okay? Now, this gets back to this fact that you don't produce anti-Rh antibodies until you're exposed to Rh positive blood, okay? So let's take a look at what might happen. Here's a pregnant woman, all right? We know that probably by looking at her belly, but I'm sure she had a pregnancy test. They're going to do blood work, and they're going to find out she's negative, okay? A negative, B negative, AB negative, O negative. The baby has a good chance of being positive, all right? And the reason is most people are positive, okay? So there's a good chance, probably 85%-ish chance, the father is positive. And then Rh positive is dominant. So if one of the parents is positive, the baby will be positive, okay? Now, if the father was negative, baby's negative, we actually don't have to be concerned, but they're not going to test. They don't test the baby, all right, because it's too invasive to test a fetal blood. They're not going to test the father because, let's be honest, we might not be 100% sure that's the father. So they're going to take this precaution whether they know what the baby's blood type is or not, okay? So every woman who is negative, we have to take some precaution. It's not as common as positive. So, if 85% of Americans are Rh positive, that means 15% are Rh negative. So 15% of pregnant women are Rh negative. So what happens is this. Let's just look at the picture. We have an Rh negative mother. There's a good chance, there's a likelihood the baby, the fetus here is Rh positive. Now, blood doesn't mix, all right? Blood doesn't cross this placenta, okay, yet, all right? So during this pregnancy, her immune system has no idea that the fetal blood is incompatible, right? Positive blood should not go into a negative person. So nothing is going to be problematic during this first pregnancy because that placenta keeps the two bloods separate from one another. Now, during delivery, okay, so during childbirth, blood vessels rupture, all right, in that placenta. So there's mom's blood in there, there's fetal blood in there, they rupture, and now as this baby's coming out, being born, some of the blood leaks into mom's blood supply and activates the immune system, all right? This baby's fine. This baby was born. But now that activated and exposed her immune system to the Rh blood, okay? And after that initial exposure, her body's going to produce anti-Rh antibodies, okay? Now, and those antibodies can be in her for a while. And Rh antibodies are small antibodies. The anti-A and anti-B are not small. They won't cross a placenta. But if you're making these anti-Rh antibodies and you get pregnant a second time, these antibodies are small and they cross the placenta and get into the fetal circulation and they start to attack the red blood cells. All right? And that has caused a lot of problems. It's known as hemolytic disease of the newborn or erythroblastosis fetalis. We used to, just think it was a natural death, in these children. And then someone made the connection that for some reason it seems to always be the second pregnancy, all right? Because she has to be first exposed and then she produces those antibodies. So the good thing someone thought about this because they figured it all out and they figured out a way to treat it, okay? So the treatment is called RhoGAM. So after we find out this pregnant woman is Rh negative, it's going to go in her chart, and roughly around week 26 to 28, and then again the day of birth or shortly after birth, she's going to be giving an injection of RhoGAM. And the RhoGAM medication is going to neutralize or block any of those Rh antigens that entered during that pregnancy. Okay. Before this, children were dying of heart failure, severe jaundice, because of this destruction of the red blood cells. So let me remind you, the concern is only with Rh negative women, pregnant women, during the second pregnancy. Okay, but in order to prevent, they have to be given RhoGAM. And if she's pregnant the second time, she's going to be given RhoGAM again in case she decides to get pregnant a third time. Now, some women don't know whether they want to get pregnant or not. Some women during this pregnancy might say, this is my last one, don't give me the RhoGAM, I'm not going to have a third. Well, usually pregnant women aren't thinking very clearly, so we don't trust them. We're going to give that woman RhoGAM anyway, in case she changes her mind or something else occurs. All right, so that's the Rh blood group. This last slide actually shows us how we determine blood type. We literally will take someone's blood and we'll just mix it with antibodies. We can make antibodies in the lab, so we can engineer and mass produce antibodies. So we'll take someone's blood. All right, here's one red blood cell. We'll mix it in with antibodies, and if it clumps the blood, so notice what the antibodies do. They grab a hold of all these red blood cells and kind of clump them all together. All right, that's called agglutination. So if that occurs, then we know that this blood must have the A antigen. All right, if it doesn't, and the blood kind of looks just like normal blood, then they must not have the A antigen. So what this shows here is if we were to take someone's blood, all right, and mix it with anti-A, anti-B, and anti-D, which is anti-Rh, it doesn't react here, so that means they don't have A. It reacts here, which means they have B, and it reacted here, which means they have Rh. So this combination means that they are B positive. All right, and you can kind of look through this one. These are all the 8 possibilities where we're mixing the blood with anti-A, anti-B, anti-Rh, and then the control is just a negative control. It's not supposed to react. So notice down here, if it clumps or agglutinates with anti-A, anti-B, and anti-Rh, that means they've got all 3 antigens. So they are A, B positive. All right? So that's how we could determine someone's blood type. All right, so that was a lot, and I understand it was a lot, but hopefully I went over it in a way that it's starting to make sense, and a little bit of work on your part, it'll make even more sense. So look for the extra video, the supplemental video on blood typing. I just have a different way of explaining it in that video that might work a little better. So this is a tough chapter. It's a long chapter. So best of luck. Get working on your study guide, guided notes, and rewatch the lectures if you need to. There's a lot of supplementary information and videos in the module. And then, like always, reach out to me if you're having any trouble.